Good morning. This is Dr. Raju Devde, Professor of Pharmacology, Kakatiya Medical College, Warangal. Today, the topic is anti-fertility drugs. They are also called as hormonal contraceptives. So, today my talk on hormonal contraceptives or anti-fertility agents will be under the headings: the introduction, need for anti-fertility agents, how should be an ideal contraceptive agent, the classification, that is female contraceptive agents, the male contraceptive agents, and future research. Now, in the introduction, the drugs which used for preventing fertilization are called as anti-fertility drugs. They are also known as contraceptive drugs, and hence the method of preventing normal process of ovulation, fertilization, and ovum implantation, nothing but pregnancy, is known as contraception or birth control. It is also called as fertility control. Now, when you look into the need for anti-fertility agents, the need of these drugs is to bring down the population growth as the mortality rate has declined and the birth rate has increased. The second need is to reduce infant and maternal mortality rate. And number 3, to prevent pregnancies that are too early, too frequent, and too many. So these are the basic needs or the need for which these anti-fertility agents are used. Now, what should be the characteristics of an ideal contraceptive agent? An ideal contraceptive agent should be, of course, 100% effective. It should be accepted. It should be inexpensive, safe. It should require minimal motivation, supervision, and maintenance. It should be very simple to use. And the pregnancy should be reversible. That means once we stop these drugs, there should be a reversible attainment of pregnancy. So all these are ideal characteristics of the contraceptives or the hormonal contraceptives should require all these ideal characteristics. Then, when you look into the classification of hormonal contraceptive agents or anti-fertility drugs, they are classified into broad 2 ways, that is hormonal and non-hormonal. In the hormonal, we have the male contraceptives, the female contraceptives. In the male, they are injectables, and Gossipol is one pill which is used in the males. In females, there are oral contraceptives, injectables, implants, and transdermal patches. When we talk about non-hormonal agents in males, non-hormonal agents are the natural mechanisms, the barrier methods, the oral agents, and the permanent methods. And in females, natural, barrier, oral, and the permanent methods. So when we talk about non-hormonal permanent method of anti-fertility, that is either in males that is vasectomy, and in females that is tubectomy. Then these hormonal anti-fertility agents are hormone preparations used for reversible suppression of fertility. So when we talk about hormonal anti-fertility drugs, they are the preparations which are used for reversible suppression of fertility. So what are these female contraceptive agents? And these female drugs, contraceptive drugs, are used over 100 million women worldwide are currently using hormonal contraceptives. With these drugs, fertility can be suppressed at our will for as long as desired, with at most 100% confidence and complete return of fertility on discontinuation of these drugs. Then the efficacy the convenience, the low cost, and overall safety of oral contraceptives has allowed women to decide if and when they will become pregnant and to plan their activities accordingly. A variety of oral and parenteral preparations are now available, which are offering individual choices. Now, when you look into the various types in females, if you look at in females, the oral preparations, that is, COCs are nothing but combined oral contraceptives. They are also called as oral contraceptive pills. They are further classified into monophasic, biphasic, and triphasic pills. And number two, the mini pill, the emergency or post-coital contraception. And number four, it is Centchroman. When we look into the parenteral preparations, they are injectables. The injectables like DMPA. DMPA is nothing but dipomedroxyprogesterone acetate. DMPA is dipomedroxyprogesterone acetate. And NETEN, NET-N is nothing but norethistyrone enanthate. Norethistyrone enanthate. So that is dipomedroxyprogesterone acetate and norethistyrone enanthate. And apart from that, injectables, they are combined preparations, and also we have implants. They are called as a Norplant and Implanon. And apart from that, we also have the transdermal patches, which are used as parenteral preparations, that is other than oral preparations. Injectable, implants, and transdermal patches in females. Apart from that, oral and parenteral, there are certain devices which are also used, like IUD, that is intrauterine device. It is not intrauterine death, it is intrauterine device, where LNG-IUS is nothing but norgestrel releasing intrauterine system. It is nothing but norgestrel releasing intrauterine system. And apart from that, there are also preparations of devices called as vaginal rings. So now we will look into one by one regarding these oral contraceptive pills or combined oral contraceptives used in females. So what are these combined oral contraceptives? These are the most frequently used agents which are used in combination oral contraceptives containing both an estrogen and progesterone preparation. So estrogen and progesterone preparations are always present in the combined oral contraceptive pills. And there are a variety of formulations and various strengths available in the market. Almost all of them contain ethinyl estradiol as the estrogen and 7-alpha alkyl 19 nortestosterone derivative as the progestin. Okay, one is ethinyl estradiol, which is present, which is nothing but the estrogen, and 17-alpha alkyl 19 nortestosterone derivative as the progestin. So all the combinations contain these two preparations, and theoretically these combined oral contraceptives efficacy is considered to be 99.9%. And the combination agents are further divided into the monophasic pills, where the constant dosage of both components during the cycle are maintained. Biphasic or triphasic pills, where the dosage of one or both of the components is changed once or twice during the menstrual cycle or during the menstrual phase. Then, when you look into the mechanism of action of these combined oral contraceptive pills, they act by preventing the ovulation, where direct measurements of the plasma hormone levels indicate that luteinizing hormone and follicular stimulating hormone levels are suppressed. And there is a mid-cycle surge of LH, which is absent. Apart from that, they also cause endogenous steroid levels, which are diminished. And hence, the ovulation does not occur. That means to say, this combined oral contraceptives can be assessed, or the action can be assessed by measurement of the plasma hormone levels, where LH and FSH levels are suppressed, mid-cycle surge of LH is absent, the endogenous steroid levels are diminished, and ovulation does not occur. Although either component alone can be shown to exert these effects in certain situations, or the combination synergistically decreases the plasma gonadotropin levels and suppresses the ovulation more consistently than either of these two combinations or alone. Now, when you look into the sex hormones and in the females, if you look at, it is nothing but it is under control of hypothalamus, pituitary, and the target female genitalia like ovaries, fallopian tubes, uterus, and cervix, the female genitalia. When you look into this, the hypothalamus, it will cause the release of gonadotropin releasing hormone, GnRH, and it will stimulate the pituitary. And this pituitary in turn will stimulate the release of LH and FSH. And this LH and FSH in turn will act upon the ovary and other female genitalia, fallopian tube, the uterus, cervix, and vagina. Okay. And you can see here, hypothalamus releasing the gonadotropin releasing hormone, and the pituitary will release the FSH and LH, and this FSH, SH, and LH in the ovary, it will act upon the growing follicle. In the growing follicle, it will cause the release of estrogen, and this released estrogen will this increased estrogen at the mid-cycle stimulates the LH secretion, luteinizing hormone secretion, and this growing follicle further will result in development of ovulation. On the other hand, if you look at the luteinizing hormone, when it is acting on the ovary, which acts upon the corpus luteum, and which causes the release of progesterone and some estrogen. And this progesterone and some amount of estrogen, which is produced by the corpus luteum, will increase the progesterone, and the estrogen after ovulation inhibit the FSH and LSH secretion. Hence, it will inhibit the hypothalamus and sends the inhibitory signals to the hypothalamus to decrease the production of GnRH. And this is how the cycle goes on. Now, when you talk about the combined oral contraceptive pills, what is the timing of their initiation? So here, actually, one tablet is taken daily for 21 days, starting on the 5th day of menstruation. And the next course is started after a gap of 7 days, in which the bleeding occurs, which is known as a pill-free period. Okay, so one tablet is taken. Actually, we have to give 21 tablets in one cycle, assuming that the normal menstrual cycle is 28 days. Okay, so we are going to start the first pill on the 5th day of menstruation, and it is continued up to 25th day of the menstrual cycle. And 26, 27, 28, and 1, 2, 3, 4 of the menstrual cycle, when the menstruation starts on the first day, those 7 days, right from 26th day to 28th day and first day of the menstrual period up to the 4th or 5th day of menstrual period, we are not going to give this combination, that is the combined oral contraceptives. But generally in some prescriptions, they do have 21 plus 7 extra tablets in that particular strip containing 28 tablets. The 21 tablets are actually the combined oral contraceptive pills, and the rest of the 7 pills may be either containing lactose, or in some preparations, they are nothing but iron and folic acid tablets. Okay, so here 21 days tablets we have to start from 5th day to 25th day, and 26, 27, 28 day and first day of the bleeding and up to 4th day of bleeding, we are not going to give any combined oral contraceptive, and this is what is called as the pill-free period. This is called as pill-free period. Okay, now when you talk about the various types of combined oral contraceptives, we have monophasic pills, and these monophasic pills are containing the same or constant amount of estrogen and progestin in each pill in one packet. And there's some popular combinations you can see here, which are being marketed and very much used across the country. That is the Mala N, Mala D, Oral 28, and Ovcon 50. So they have all these preparations have the estrogen and progestin preparations. When you talk about Mala N, ethinyl estradiol is 0.03 micrograms, norgestrel is 0.3 micrograms. Mala D, it is 0.03, and again D-norgestrel, it is 0.3 micrograms. Overall 28, ethinyl estradiol 0.05 micrograms, and DL norgestrel, it is 0.5 milligrams. Sorry, it is milligrams, not micrograms. It is milligrams. Then we look at into Ovcan 50. Ethinyl estradiol is 0.05 milligrams. Norethindrone is 1 milligram. So here the combination is same like ethinyl estradiol, norgestrel, estrogen and progestin, but a slight variation in the combination is available as Mala N, Mala D, overall 28, and Ovcan 50. Now coming to the biphasic pills. So these biphasic pills, they deliver the same amount of estrogen each day, but level of progestin is increased about halfway throughout the cycle. Okay. So here in biphasic pills, what is happening? These biphasic pills, they deliver the same amount of estrogen each day, but the level of progestin is increased about halfway through the cycle. If you look at this orthonovum, which is segment 10 by 11 and 10 by 11 Nikon. So day 1, it is 1 to 10th day, ethinyl estradiol is 0.035 milligrams, whereas norethindrone, it is 0.5 milligrams. Whereas from day 11 to day 21, ethinyl estradiol, again the same concentration, 0.035 milligrams, whereas norethindrone is increased to 1 milligrams up to from 11th day to 21 day. That is why they are called as biphasic pills. So here the progesterone concentration is increased to double after the mid half of the menstrual cycle. Then when you look into the triphasic pills, why they are called as triphasic pills? Because they contain high dose of estrogen. They contain high dose of estrogen in the mid cycle with increasing doses of progestin given over 3 successive phases. So biphasic, we are having 2 phases. Triphasic, we are having 3 phases. For example, if you look at 1 to 6 days, ethinyl estradiol, it is 30 micrograms and norgestrel, it is 0.05 milligrams. 7 to 11 day, ethinyl estradiol is 40 micrograms. Norgestrel, it is 0.075 micrograms. When you look at 12 to 21 days, ethinyl estradiol is 30 micrograms, it is reduced. Norgestrel is 0.125 milligrams. That means to say here, progesterone or the progestin doses are gradually increasing over the 3 phases. So that is why it is called as triphasic. And also in the 1 to 6 and 7 to 11 days, ethinyl estradiol dose is also increased from 30 micrograms to 40 micrograms. And then it is reduced to 30 micrograms in 12 to 21 days. These are called as triphasic pills. Now, what are the adverse effects of these combined oral contraceptive pills? They are mild to moderate and severe adverse drug reactions. When you talk about these mild adverse drug reactions, they are mainly due to estrogenic side effects. So mild are mainly due to estrogenic as well as progesteronic. So estrogenic side effects are nausea, breast tenderness, breakthrough bleeding, headache, which is often mild and transient, and it may also worsen the onset of migraine. These are the estrogenic side effects, mild side effects. When you look into the progesterogenic side effects, there is an increase in the appetite, there is hirsutism, decrease in the libido, increase of the body temperature, weight gain, and acne. So this is the weight gain, hirsutism, and acne. So So these are the progesterone related side effects or adverse reactions. Progesterone related side effects. Now, when you look into the moderate as adverse effects, this may require discontinuation of the therapy, which is due to estrogenic side effects, because the moderate adverse drug reactions with combined oral contraceptives are related to estrogenic as well as the progestogenic. So in estrogenic side effects, they are vertigo, leg and uterine cramps, and precipitation of diabetes. So when you have these moderate adverse effects, if there is vertigo, it may result in discontinuation of this anti-fertility agents. When you look into the progestogenic side effects, there is breakthrough bleeding, but not with phased regimens. There are vaginal infections, amenorrhea, following cessation of as administration of oral contraceptive pills. So the progestogenic effects of the oral contraceptive pills or combined oral contraceptives are the moderate side effects, that is amenorrhea following cessation of the oral contraceptives. Then when you look into the serious or severe adverse drug reactions, which may definitely result in stoppage of contraceptive pills, they are vascular side effects. And these vascular side effects may be venous thromboembolism or deep vein thrombosis. The incidence is actually 3:1000. It may also cause cerebrothrombosis. The incidence is 1.5:1000 population or the drug users. And it may also cause hypertension and myocardial infarction. Apart from this, there are other side effects which are called as gastrointestinal side effects. These gastrointestinal side effects are cholestatic jaundice, hepatic adenomas, and the other side effects like depression. And in the other side effects, if you look into, in addition to the above effects, a number of adverse reactions have been reported for which a causal relation has not been established. They include alopecia, erythema multiforme, erythema nodosum, and other skin disorders. Actually, when an individual, a female, takes the drugs as a serious side effect, the other side effects where the causal relationship is not established but may result in development of alopecia, erythema multiforme, erythema nodosum, and other skin disorders. So these are the various side effects which are associated with combined oral contraceptives. When you look into the contraindications of the COCs, they are absolute contraindicated. The absolute contraindications are thromboembolic disorders, coronary and cerebrovascular disorders, or a history of thromboembolic or coronary and cerebrovascular disorders. And moderate to severe hypertension is also a absolute contraindication. Apart from that, active liver disease, hepatoma, or history of jaundice during the past pregnancy is also a absolute contraindication. Then suspected or overt malignancy of the genitals or breast is an absolute contraindication. Porphyria, then impending major surgery to avoid post-operative thromboembolism is an absolute contraindication. When you look into the relative contraindications, which may require avoidance or caution during the use of COCs under supervision, they are diabetes. That means to say, in diabetes, we can avoid, or one can be cautious when they are using COCs in diabetes, where control may be deviated. And apart from that, obesity, smoking, undiagnosed vaginal bleeding, uterine leiomyoma may enlarge with estrogenic preparations, and progesterone-only pills can be used in uterine leiomyoma. There should not be a combined preparation. COCs cannot be used in uterine leiomyoma, so it will become a relative contraindication because the estrogen preparations may increase the leiomyoma, whereas only progesterone-only POPs or progesterone-only pills can be used. In mentally ill patients where oral contraceptives decreases the epileptic threshold and may precipitate seizures or seizure-like disorders. And above the age of 35 years, it is then relative contraindication, mild hypertension, migraine, and gallbladder disease. They are the relative contraindications. Then we'll look into the other aspects. They are the mini pills. So why they are called as mini pills? It has been devised to eliminate the estrogen because many of the long-term risks have been described or ascribed to this component. So all the side effects what we have seen, that is a mild or a moderate or severe side effects, are mainly related with estrogen related side effects. A low dose progesterone only pill or a mini pill, it's also called as mini pill or low dose progesterone only pill, POP, is taken daily continuously without any gap. The menstrual cycle tends to become irregular and ovulation occurs in 20 to 30% of women, but other mechanisms contribute to the contraceptive action. The efficacy is very low when compared to that of COCs or combined oral contraceptives, to 96 to 98%. And look for pregnancy if amenorrhea, and we have to look for pregnancy if amenorrhea or more than 2 months occurs. This method is less popular because of its efficacy, which is low when compared to that of oral contraceptive pills. Now, when you look into the mechanism of POP, that is progesterone only pill or a mini pill, it is effective. It is their effectiveness, or its effectiveness, is thought to be largely due to a thinning of the endometrial lining that impairs the implantation of the ovum, and there is thickening of the cervical mucus which decreases the sperm penetration, and it also slows down the ovum transport. So there are three mechanisms. One is thinning of the endometrial lining, which will result in impairment of the implantation of the ovum. Number two, there is thickening of the cervical mucus, which decreases the sperm penetration. Number three, there is slowing down of ovum transport. The adverse effects of mini pill are frequently encountered side effects, and the major reason women discontinue the use of all these type of progesterone only contraceptives are the episodes of irregular and unpredictable spotting and breakthrough bleeding. So this is one of the major drawbacks with mini pill or progesterone only pill, low dose progesterone only pill, that is irregular and episodes of irregular bleeding, unpredictable spotting, and breakthrough bleeding. Then the third contraceptive mechanism is emergency contraceptives or postcoital contraception. So postcoital or emergency contraception is indicated for use in cases of mechanical failure or barrier devices, or in circumstances of unprotected intercourse like the rape and all other medical legal aspects of pregnancy. Then what is the mechanism of action of this postcoital contraceptive pill? The mechanism of action of these are not fully understood, but their efficacy clearly cannot be accounted for solely by inhibition of ovulation. The other potential mechanisms of action include effects on the gamete function and survival and on implantation. These agents do not affect the established pregnancies. Whenever there's an established pregnancy, they are not going to affect, especially the postcoital contraceptive pills or emergency contraceptive pills. Now, there are currently three regimens available as emergency contraception. One is levonorgestrel 0.5 milligrams and ethinyl estradiol 0.1 milligrams, where one can take 2 tablets of Overall as early as possible within 72 hours of unprotected intercourse and repeated after 12 hours. Till recently, this regimen was called the USP method, has been the most popular method. USP method is the most popular method where one can take a levonorgestrel 0.5 milligrams plus ethinyl estradiol 1 milligram, that is 2 tablets of Overall as early as possible within 72 hours of unprotected intercourse. and it can be repeated after 12 hours. So it is estimated to prevent 3 out of 4 possible pregnancies, but nearly 50% women experience nausea and 20% may result in development of vomiting. Then there's another method which is called as mifepristone. So this mifepristone is available in the form of a tablet, which is 600 milligrams single dose taken within 72 hours of intercourse, has been used in China, Europe, and few other countries with high success and few side effects than USP method. So this mifepristone is more better when compared to that of your overall tablets, which are have to be taken 2 tablets immediately within 72 hours, followed by another 2 tablets after 12 hours. Okay. So mifepristone has to be taken in a single dose within 72 hours of unprotected intercourse. Then this levonorgestrel alone, which is available in the form of 0.75 milligrams. This is the third regimen. So second regimen is mifepristone. First regimen is overall levonorgestrel ethinyl estradiol, mifepristone. The third regimen of postcoital contraception is levonorgestrel alone, or as a single pill, 0.75 milligrams, taken twice with 12 hours gap within 72 hours of unprotected intercourse. And the trials conducted globally by the WHO found this regimen to be 2 to 3 times more effective and better tolerated than the above regimens. And the incidence of vomiting is only 6%, and other side effects are also less. The WHO Essential Drug List in 2001 recommended the replacement of WISP method by this regimen with the presence of availability of E26, EC2 pill or pill 72 or E-pill, and there are some I-pill and I-can. And when you look into this mifepristone, there's also a pill here. And then we have a plan B, one step, the first regime, second regime, the third regime, I-pill, which is more marketed nowadays. That is levonorgestrel only pill, which is having only levonorgestrel, and it is more safe when compared to the USP regimen. Then when you look into the method, that is USP or neonorgestrel or mifepristone, the time between the dose and unprotected sexual intercourse, the time between the dose and unprotected sexual intercourse is less than 72 hours, levonorgestrel less than 120 hours, and mifepristone less than 120 hours. The pregnancy rate is 2% with USP, levonorgestrel 1.6%, and with mifepristone is only 1.3%. And the prevented pregnancies are 74%, 80% with levonorgestrel, and 83% with mifepristone. So mifepristone is having a better outcome when compared to that of USP regimen and the levonorgestrel regimen. Now, there's one more drug which is called as SPRM, that is selective progesterone receptor modulator. Like we have selective estrogen receptor modulators, this is selective progesterone receptor modulators like ulipristal or ulipristal acetate. So this ulipristal acetate has to be given in a single oral dose of 30 milligrams, is more effective if it is taken in within 120 hours or within 5 days of unprotected sexual intercourse, or within 120 hours of within 5 days of sexual intercourse. And this is actually used for the treatment of postcoital contraceptive or emergency contraceptive method. If these measures fail, pregnancy should be terminated to avoid teratogenic deformities of the fetus. So by using all the above oral contraceptives which are available, like the monophasic, biphasic, triphasic, and then progesterone only pill, and then coming to the emergency contraceptive methods like the 3 methods, even in spite of that, there is a failure or there's a failure of the methods and the pregnancy results, we need to terminate the pregnancy to avoid the teratogenic effects in the fetus. Now, if you look at the Centchroman, this is also called as ormeloxifene. Ormeloxifene is nothing but Centchroman. This is a non-steroidal contraceptive or selective estrogen receptor modulator developed at the CDRI, that is Central Drug Research Institute in Kasauli. Okay, this is a non-steroidal contraceptive or selective estrogen receptor modulator developed at the CDRI, the Central Drug Research Institute, Kasauli, under the brand name Saheli, which has become very popular. And it is available in the dose of 30 milligrams of Centchroman in each tablet, where the failure rate is 1 to 3%, which has been recorded till now. So Centchroman is also called as Saheli or meloxifene, which is a selective estrogen receptor modulator or non-steroidal contraceptive, that is Centchroman. Now, what is the mechanism of action of Centchroman? It is a potent competitive and agonist at the peripheral estrogen receptors and suppresses the proliferative stage of the endometrium. It also accelerates the ovum transport without affecting the ovulation, and it desynchronizes the event of ovum transport with endometrial phases of the development. So the time of initiation of Centchroman, unlike other hormonal oral contraceptives, which are taken daily for 21 days followed by 7 days of pill-free period, Centchroman is taken twice in a week for first 3 months and later on once a week subsequently to be continued irrespective of the following menstrual cycles as long as contraception is desired. So this is one major advantage of this particular Centchroman or ormeloxifene, where what we have to do, this Centchroman has to be taken twice a week for the first 3 months, then followed by once a week subsequently to be continued irrespective of the following menstrual cycles as long as the contraception is desired. So this is actually a very good method, but the first tablet should be taken on the first day of the menstrual cycle. That is, for example, if it is a Sunday, then the second tablet should be taken on the 4th day of the menstrual cycle. For example, it is Wednesday, and subsequently 2 tablets are to be taken on every Sunday and Wednesday for first 3 months, followed by once a week on the same day every week, that is Sunday or Wednesday as the case may be. And then the missed tablet should be taken as soon as possible and the normal schedule should then be adhered to. If the dose is missed by 2 to 7 days, the normal dose schedule is maintained, but the mechanical barrier contraception or condoms are used as preventive measures additionally till the next menstrual period. If the dose is missed for more than 7 days, reinitiate the bi-weekly schedule for 3 months and weekly schedule thereafter. That means to say, once the dose is missed by 2 to 7 days, the normal dose schedule is maintained by mechanical barrier methods like condoms and are used as a preventive measure additionally till the next menstrual period. If the dose is missed for more than 7 days, reinitiate the bi-weekly schedule for 3 months and weekly schedule thereafter. Then the contraceptive effect of the Centchroman is readily reversible within 6 months after stoppage of Centchroman, and subsequent pregnancy may be normal. Then the newborns present normal milestones and have no congenital abnormalities. If pregnancy occurs, the treatment should be discontinued and the pregnancy should follow the natural course as there is no risk of teratogenesis with Centchroman. When you look at the combined oral contraceptives or estrogen progesterone related contraceptives, once there is a failure of contraceptive, and the pregnancy occurs, we need to terminate the pregnancy. But with contraceptive like the Centchroman does not cause teratogenesis. Hence, even if there is a failure of contraception with Centchroman, the pregnancy can be followed, or the pregnancy can be maintained, where there's a natural cause and there is no risk of teratogenesis. But when you look into the adverse effects, occasionally the menstrual cycle is likely to be prolonged in about 8% of the individuals, which is of no consequence if tablets have not been missed. Now, when you look into the contraindications of Centchroman, the contraindications are jaundice or hepatic dysfunction, cervical hyperplasia, hypersensitivity reactions. And apart from that, polycystic ovarian disease, the tuberculosis, or the renal disease. These are the contraindications for the use of Centchroman. Now, what are the interactions of oral contraceptive pills? The contraceptive failure may occur if the following drugs are used concomitantly. For example, the enzyme inducers. Suppose the oral contraceptive pills are used with enzyme, that is microsomal enzyme inducers like phenytoin, phenobarbital, primidone, carbamazepine, rifampin or rifampicin. The metabolism of estrogenic as well as the progestational component is increased and hence result in the failure of contraception. Then the other interactions of these oral contraceptives are suppression of the intestinal microflora or microflora. So this can occur when these oral contraceptives are used along with tetracyclines or ampicillin, etc., which may cause problems by impairing the bacterial flora responsible for recycling ethinyl estradiol from the large bowel. So with both types of interacting drugs, it is wise to switch over to a preparation containing 50 to 80 micrograms of ethinyl estradiol, or to use alternative method of contraception. Either we have to increase the dose of ethinyl estradiol or change to other alternative contraceptive method. Now, what are the non-contraceptive benefits of combined oral contraceptive agents? There are some non-contraceptive benefits also. They will cause improvement in the menstrual abnormalities. They give a protection against cancer, especially the endometrial and ovarian cancer. There's a reduction in the risk by 40%, and it also gives a protection against certain health diseases like the pelvic inflammatory disease, the endometriosis, the fibroid uterus, benign breast diseases, and the ovarian cysts. So these are the added advantages of the combined oral contraceptives, which are non-contraceptive benefits associated with combined oral contraceptive agents. Then coming to the parenteral contraceptives. These parenteral contraceptives, they are called as injectable drugs or the injectable agents. These have been developed to obviate need for daily ingestion of pills. They are given in intramuscular or as oily solutions. They are highly effective, and over 50 million women are using these so far. There are two types of preparations which are tested. They are long-acting progestin alone injections, which is injected once in 2 to 3 months depending on the steroid and its amount or concentration. Two compounds have been marketed, that is DMPA, that is dipomedroxyprogesterone acetate, and norethindrone, that is norethindrone enanthate or norethindrone enanthate. Okay, so this is norethindrone enanthate. So dipomedroxyprogesterone acetate and norethindrone enanthate are the true injectable drugs available for used as the contraceptive agents, injectable contraceptives. They are useful in the patients where compliance is a problem, or in patients having heavy menstrual bleeding, or in those for whom estrogens are contraindicated. Example, those suffering from migraine, thromboembolism, edema, hypertension, and diabetes. So in these category of women, we do use injectable preparations like DMPA and uh, uh, NET-N. Okay. So mode of action is same as that of the mechanism of action is similar to that of mini pills, and the side effects include irregular bleeding, ending up in amenorrhea and anovulation. Osteoporosis may occur on prolonged use, and gonadotropin suppression may cause low estrogen levels. There may be weight gain and increased risk of breast cancer with this particular injectable drugs. If pregnancy occurs, it should be terminated to avoid the risk of congenital abnormalities. And there is another preparation where there is a combination of long-acting progestin plus long-acting estrogen. That is estrogen, progestin, injectable contraceptives. And the most widely used formulation is number 1, developed in China. This is estradiol valeriate 5 milligrams plus 17 hydroxy progesterone caprioate, that is 250 milligrams, to be given intramuscularly every month. The other combination contains estradiol cypionate 5 milligrams plus dipomedroxyprogesterone acetate, that is 25 milligrams, to be given intramuscularly once in 2 months. The advantages of such long-acting injectable contraceptives are that they provide a single defined and predictable bleeding every month and have high contraceptive efficacy. The mechanism of action and side effect resemble similar to that of the combined oral contraceptive pills. Then when we talk about these implants, the implants are they are the drug delivery systems which are implanted under the skin, from which the steroid is released slowly over a period of 1 to 5 years. They consist of either biodegradable polymeric matrices which do not need to be removed after expiry, and the second one is non-biodegradable rubber membranes which have to be removed after the expiry. So they release they release the drug over a period of 1 to 5 years. They are biodegradable polymeric matrices which should not be removed even after expiry, and there are non-biodegradable rubber membranes which have to be removed after the expiry. The contraceptive implant is a small flexible plastic rod that's placed under the skin in one's upper arm by a doctor or a nurse. It releases the hormone progesterone into the bloodstream to prevent pregnancy and lasts for about 1 to 5 years with an average of 3 years. Then we have another method of contraception which is called as transdermal patch. A contraceptive patch, also known as the patch, is a transdermal patch applied to the skin that release synthetic estrogen and progestin hormones to prevent pregnancy. And these transdermal patches have been shown to be as effective as combined oral contraceptive pills with perfect use, and the patch may be more effective in typical use. The only currently available contraceptive patches are Xulane or after Ortho-Evra and Evra. So Xulane, so earlier we had Ortho-Evra and Evra, now we have Xulane. The sites of application are the buttocks, the upper outer arm, the lower abdomen, back, and the upper torso. These are the sites of application of the transdermal patch, which contain both the synthetic estrogen as well as the progesterone. Now, what is the method of use of these transdermal patches? So the method of use is a contraceptive patch cycle consists of 3 patches over 21 days, followed by 7 patch-free days. Each patch is applied on the same day of the week and is worn for 7 full days. For example, if you look at the first patch, first week up to second, that is second patch start of second week, third patch start of third week, in a 28-day menstrual cycle, and 1 week is patch free. Now, what are the adverse effects of these transdermal patches? The most frequent adverse effects reported while using Ortho Evra or Evra patch were are the breast discomfort, the engorgement of the breast or pain, which is seen in 22% of the women. There is headache in 21%, application site reaction seen in 17%, nausea in 17%, upper respiratory tract infection in 10%, menstrual cramps in 10%, abdominal pain in 9%, and breakthrough bleeding is also reported. The percentage is not mentioned. Then when you look into the devices, we do have intrauterine inserts or intrauterine devices. They are relatively new intrauterine contraceptive device releases levonorgestrel at a rate of 20 micrograms per day into the uterine cavity for a period of 5 years. So these intrauterine devices, which consist of levonorgestrel, which can release 20 micrograms per day of levonorgestrel into the uterine cavity sustainedly for a period of 5 years. The progestin preparation acts locally on the endometrium, and hence systemic side effects are minimal. So the return of fertility is immediate after the removal of the intrauterine device. What are the complications of the intrauterine devices? The intrauterine devices are generally well tolerated, although complications related to the device and that side effects related to progestin can occur. So related to the device are expulsion, uterine perforation. Related to progesterone is irregular bleeding, pelvic infections, ectopic pregnancy, the pain, and the pregnancy, the failure rate in first year is 3%. So these are the complications associated with intrauterine devices. When you talk about the vaginal rings, the contraceptive vaginal ring is a flexible, transparent plastic ring. It is placed in the vagina where it releases two hormones like estrogen and the progesterone. The first vaginal contraceptive ring, which is called as Nova ring, was approved by US FDA in 2001 and marketed in the year 2002. So this Nova ring, it releases 15 micrograms of ethinyl estradiol and 120 micrograms of etonorgestrel over 24 hours and used for 21 days followed by 7-day hormone-free interval completely inhibits the ovulation. But the adverse effects are vaginitis, leukorrhea, headache, and expulsion of the vaginal ring. Then we have the other hormonal contraceptives which are used in the males. They are called as male anti-fertility agents. Despite the improvement in the modern female contraceptive methods and the ability to rapidly introduce new effective methods to the developing countries, there are unmet needs for family planning in women. 15 women ranging from 15 to 49 years, and achieving the desired number of children is beneficial to women, families, and society. In order to meet the unmet need for the women, countries need to make available modern contraceptives which provide high quality services and improve the access to such services. In addition, development of new methods of contraception involving men should also be one of the priorities. Hence, male anti-fertility agents also are available in the market for their use. So, what are the drugs and approaches which are tried in the male? They are the anti-androgens. So, what are these anti-androgens? These anti-androgens act by direct action on the testes, which causes unacceptable loss of libido. Number two, estrogens and progestins act by suppressing the gonadotropins, which cause unacceptable feminization. Number three, androgens, which inhibit the gonadotropins but have poor efficacy. Hence, combination with progestin is more efficacious, which preserves the libido but is still not reliable. Then we have number four, that is the superactive gonadotropin releasing hormone analogs. So this superactive gonadotropin releasing hormone analogs They inhibit gonadotropin release after continued action. They also inhibit the testosterone secretion, but they produce impotence and loss of libido, which is again a concern in the male. Then there are certain cytotoxic drugs like cadmium, nitrofurans, and indoles, which suppress spermatogenesis but are toxic, often produce irreversible action. So it may also produce irreversible suppression of spermatogenesis, which is not a desired effect in the males. Hence, when you look at the male contraceptive pills, which is used actually is Gossipol, that is called as male only pill Gossipol, male only pill Gossipol. It is a non-steroidal compound obtained from cotton seed, which has been studied in China. It is very effective orally and causes suppression of spermatogenesis in 99% of the men, and it reduces the sperm motility. And infertility develops after a couple of months. So fertility is restored several months after the discontinuation of Gossipol. It is derived from the cotton seed in China, obtained from a cotton seed plant. It is widely studied in China. However, about 10% of the men remain oligozoospermic for long periods after discontinuation. And during the treatment of Gossipol, serum luteinizing hormone and testosterone levels do not change. So, libido and potency are not affected with Gossipol. It has no hormonal or anti-hormonal activity. The mechanism of action of Gossipol is not very much certain, and the suggested dose of Gossipol is 20 milligrams per day for 2 to 3 months, followed by 40 to 60 milligrams per week. And it is most important adverse effect is hypokalemia due to renal loss of potassium, which with its attendant muscular weakness, even paralysis, that is hypokalemic paralysis. Okay. Then other side effects are edema, diarrhea, breathlessness, and neuritis. Then coming to after knowing all these, like for example, the Gossipol, as it is having various effects on the spermatogenesis, but the only problem with this Gossipol is when once it suppresses the spermatogenesis 99% of the men and reduces the sperm mortality, the infertility develops after a few months. So after starting Gossipol, one has to maintain some other methods to prevent pregnancy by barrier methods or some other method, because the infertility after using of Gossipol starts after a couple of months. That is very important. One has to very much understand. And the suggested dose of Gossipol is 20 milligrams per day for 2 to 3 months, followed by 40 to 60 milligrams per week. The most important adverse effect is hypokalemia, resulting in severe muscular weakness, that is called a hypokalemic paralysis. And the other side effects are edema, diarrhea, breathlessness, and neuritis. So hence, till now we have discussed about the various contraceptive methods available in the females, the contraceptive methods available in the males. And to end with this lecture, we like to see regarding the future research. So here, the contraception is becoming a very important process to maintain various aspects of the life, as the maternal mortality, to reduce the maternal mortality and the infant mortality, and also the living standards are very much increased, so to reduce the birth rate and all those things. So what are the future research aspects in the contraceptives? The research has been focusing on non-hormonal aspects of contraception. So the contraceptive vaccines provide a real opportunity for effective contraception. This is one future prospect. That is the vaccines for contraceptive vaccines. And HCG containing vaccines are of great interest as they are formed by early embryos, not the pregnant female, hence providing the least side effects when inhibited. Then they are the first CV to pass the contraceptive vaccines. They are the first contraceptive vaccines to pass phase 1 and phase 2 clinical trials successfully. And an immunological approach to contraception remains an innovative idea and has been proven effective in both experimental and clinical trials. If the ongoing trials remain successful, the contraceptive vaccines will mark another progress in the field of mass contraception, and its implication or implementation would hopefully reduce the current prevalence of unintended pregnancies. With this, I think I'll come to the end of my talk. Thank you very much.